Welcome to February 2025 Rehabilitation and Movement Science Grand Rounds. This month we have with us Dr. Paul Furst, who's going to talk to us about what do patients with low back pain need. Dr. Furst graduated from East Stroudsburg University with a Bachelor of Science in Biology and received his Doctor of Physical Therapy degree from Drexel University. He is board certified in orthopedic physical therapy and certified as a therapeutic pain specialist. He is also a retired certified strength and conditioning specialist, and he's currently a fellow in the St. Luke's University Health Network Spine Fellowship. Dr. Furst's clinical focus involves the analysis of movement impairments and correction via motor learning strategies and using a multimodal, hands-on approach. He enjoys deriving new treatment techniques to maximize patient outcomes to improve patient self-efficacy and reductions in pain catastrophizing and chronic disease avoidance. When he's not at work, he enjoys taking his dog for trail walks, hiking in nature, playing basketball, feeling connected to his community by attending sporting events with his wife and daughter. As a reminder, make sure that you scan the QR code or sign in with the code that's on the screen, and make sure you do so within the 24-hour window when it's available. If you're watching the recorded version of this, you can ignore that part and just continue watching this video. And no matter what, make sure you take the quiz at the end of this course and also the course evaluation. We do look at the feedback and we very much appreciate it. So this is our statement of need, and the target audience is all providers. This is our designation statement, and the planners and presenters have nothing to disclose. And now I will turn it over to Dr. Furst.
Hi, everyone. Thank you so much, Steve, and the rest of the Spine Fellowship faculty for having me here today. I'm super excited to talk about something that I'm very passionate about. A lot of my background and studies have focused a lot in the treatment of chronic pain. I've studied with Adrian Lowe and within his therapeutic pain specialist program. And this is something I have a lot of passion about, helping patients sort of discover the underlying causes and the root issues behind their low back issues, things that have been lasting for a long period of time. So today, I hope to establish these learning objectives so that you guys learn a little bit more about my new approach or gain some novel aspects towards how you can change your treatments. So with that, I'm hoping to define the chronic pain pandemic of low back pain and the risk factors for its development, identify the current models of healthcare and how that influences chronicity risk development, discuss how self-efficacy building is a key to chronicity risk aversion, propose some recommendations and the current evidence on enhancing pain self-efficacy, as well as pain self-efficacy in general for low back pain. And then from there, hopefully you guys can gain some new ways to improve your ability to incorporate that into practice and helping your patients build pain self-efficacy. So that said, I want to have you take a step back and put yourselves back in the shoes of yourself as a 4-year-old. Imagine yourself running down the street playing with a friend. Your friend kicks the ball down the road, and as a reluctant participant, you chase after it. As you're chasing after it, your foot hits a crevice within the road, and you subsequently fall down, scrape your knee, just like this little boy here. Within that instant, you have a sudden flush of pain that sort of fills your mind, and it's something new, something you've never experienced before. You have gushing blood, and you look around in bewilderment, wondering what just happened. You look for mom, you look for dad, you want help, right? And from there, luckily, mom or dad are right down the road, and they run over to you, clean you up a little bit, put a little antiseptic on that new abrasion or laceration, and give you a Band-Aid. All's good. And hopefully within a couple years, you don't ever need mom or dad again, and you're able to apply and clean your wound yourself and give yourself a Band-Aid. Essentially, why this matters and why we're even talking about this is our patients who have been dealing with back pain are essentially like these 4-year-old children. It's a new sensation for them. They're not really sure on what to do or how to apply their proverbial Band-Aid. And for us as clinicians or healthcare workers, physicians, et cetera, we're the ones who can help them apply that Band-Aid. But hopefully after today's talk, I teach you how to apply that so that they can apply it themselves so that they don't necessarily need us. And that's the essence of what today's talk is on how to build self-efficacy towards their pain, specifically low back pain. I think the reason why we have trouble with doing this, having our patients apply their Band-Aid, is because they're not clear on what their pain is. Like I said, it's a new sensation. But the issue there too is also physicians and physical therapists and other healthcare workers. The definition of pain is somewhat vague as well too, or it's sort of a mystery in some ways. And so this is the International Association for the Study of Pain's definition, which is essentially an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The point here is if you look at the diagram towards the right, pain comes from different inputs, coming from the environment as well as the injured tissue that runs through the dorsal root ganglion, up the spinal cord, through the brain stem, and then up to the cortex. And that's sort of where we have trouble. That's where patients run into their issues in terms of how they output or respond towards their pain. It's the scrutinization process. And I think that is what today's focus is on how we can be better at improving our patients' scrutinization of their pain. That's why it's important to be clear about what pain is, but also what chronic pain is. Chronic pain is essentially pain that has arisen or arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptors. It's such a challenge, right? There's no real cause of patients having pain, despite the fact that it's healed 3 months later. And why are you still in pain despite the fact? I think it's important for us to be clear on how it develops too, as clinicians and practitioners, so we can explain that to our patients more effectively. We have to explain that despite pain has lasted longer than 3 months since the date of injury, that pain is persistent and that it's very common. 40% of patients, that's 2/5 of people that walk in your door who have acute low back pain, go on to develop chronic low back pain. And the reason for that stems from sort of their cognitive affective or their behavior towards their pain. That's what leads to peripheral and central changes, which keeps pain peripherally sensitive and why pain persists for long periods of time. It's their behavior towards their pain or their scrutinization, like I mentioned in the slide before. And the reason why it's an issue, why the scrutinization process continues to be leading towards peripheral sensitization or central sensitization issues, is it's because of our patients' lack of education on their pain. And it's their poor ability to manage or apply that proverbial Band-Aid, like I mentioned before. And not necessarily a Band-Aid, it's more your ability to manage and come up with better ways to have a healthy lifestyle and treat your back appropriately. And all that essentially comes from poor self-efficacy or self-belief that you can treat yourself or help yourself. And so again, this sort of further illustrates how scrutinization can affect or lead towards plastic sensitization or peripheral sensitization. Stress in general can affect cortisol levels. As you see to the diagram to the right, chronic stress leads to the limbic system hypertrophying. That's like our emotional response towards pain. So when you have excessive amounts of stress and cortisol level elevations, obviously our patients are going to have more emotional response towards their symptoms. And this is going to in turn lead to altered condition pain modulation. Our natural ability to fight pain peripherally as well as centrally is through the endogenous opiate system. Patients who have this limbic system hypertrophy go on to have a depression in the circulating endogenous opiates, as well as an increase in circulating interleukin-6 cytokines, which leads to peripheral sensitization, altered nerve phenotypes, and cortex changes. Such a challenge, right? And it all stems from the way that our patients are behaving towards their pain. This is sort of how they're behaving, right? They're acting like that 4-year-old kid who just scraped their knee for the first time, except it's a 45 or 55 or 65-year-old person who's got other issues in their life, like all these yellow flags that you see here with anxiety, money issues, family issues, contrasting opinions and different medical opinions that have led to sort of their inability to understand where or what route they need to take. So they're left with their gears turning like this gentleman down low here and faced with many different roads that they need to take or have choices to take, but really no map or no understanding on where they need to go. And that if you just put yourself in the shoes of our patients here with chronic issues, they can feel essentially lost. And that's why they have trouble. That's why these symptoms persist for a long period of time. And so I believe that the way that we can treat this or help our patients through this lost city or this scraped knee, even though it represents their low back, is through the cortex, right? It's having a belief that they can triumph, that they can overcome their pain and do the things that they need to do for everyday life. Just like Michael believed he could fly, or Mia believed that she could taste gold, just like Muhammad believed he was the greatest of all time, or like the four gentlemen in the bottom left-hand corner believed they could change the technological world, so that they could all be just like Rocky and triumph over their opponents. And it essentially is this. It's from what was originally defined from Albert Bandura as self-efficacy. And people need to feel a sense of struggle and then overcome that struggle with resilience in order to really have a good sense of success and self-efficacy. And my hope today is that after understanding a little bit more about what self-efficacy is, you can take some of my new approaches here on building it and help your patients also succeed and build their own self-efficacy towards their low backs. Why does this matter, though? Why are we even talking about this? It's been such an issue for the world, chronic pain in general. As of 2020, low back pain has affected over 619 million people globally, and 843 million cases are projected by 2050, which are largely driven by population expansion and aging. Low back pain is thought to be the leading cause of disability worldwide and a condition in which the greatest number of people may benefit from rehab. It's experienced at any age. Most people who experience low back pain experience it at least once in their life. It's super prevalent, mostly in the ages from 50 to 55, but all the way up to 80, and it's more noted in women as well. One thing that's important to note is that non-specific low back pain is most common presentation of low back pain. That's basically no specific cause, nothing that they can find on an image that's the true root cause of their pain, 90% of cases. And this was taken from the World Health Organization in 2023, some of these stats here. The point here also is that it was traditionally treated with prescription pain meds like opioids, which has led to increased overdoses and morbidity rates skyrocketing as a result of chronic pain. Just to paint more of a clear picture here, it's been a huge public health crisis for the United States. And some of these numbers are a little bit more outdated from 2011, but here's kind of what paints the picture here is that persistent pain has been more prevalent than cardiovascular disease, cancer, and diabetes. Super costly too. Again, these numbers are a little bit outdated, but nonetheless, you get the idea that over 328 million prescriptions have been provided for persistent pain and over $13 billion in sales. It was so noted that The Lancet, which is a prestigious journal that really releases the highest level of evidence towards science and bettering the field of health, released their own series in 2018 on low backs. And they went on to describe again that low back pain is the #1 cause of disability in the world from children to elderly, mostly in middle and low income countries. But an interesting stat is that over 42.6 million years have lived with disability of all ages. It's so prevalent that within the US and the UK, 50 and 48% of people go out to seek low back pain care annually. So we obviously need to do something about it. From there, Buckbinder, which was released in 2020, put out an article that sort of highlighted some of the main takes from The Lancet. They went on to say that there was a surge in global low-value care, and how they defined that was that there's been a liberal use of diagnostic imaging within the emergency departments, increased prescription of opioids, spinal injections, which has led to surgery and skyrocketing medical human costs. They went on to also say that in 2012, there was a US VA study that found that 59% of outpatient lumbar spine screens were considered inappropriate. In 2019, Buckbinder also highlighted that there was a systematic review of 14 studies that found evidence that imaging is also associated with higher medical costs, increased healthcare utilization, and more work absence with non-image groups, meaning that we're over-prescribing, we're over-imaging, which is fueling catastrophization and disability. So that's considered low-value care, obviously. What they went on to say, Buckbinder said there needs to be more of an urgency to consider more high-value care, and the way they define that is using more culturally sensitive and context-specific biopsychosocial interventions. Kind of a new trend nowadays, but I think it's catching wind. London, within Buckbinder, they also released London's National Institute of Clinical Excellence's proposal on how we could address low back pain. There's 10 different proposals there. The way I summarize them is this, which, these are my main action plan keys for at least physical therapists is as well as physicians, that we need to make sure that patients are taught to self-manage their low back pain, seek out care only when it's needed, discourage misinformation about low back pain among healthcare professionals and patients, address the gaps within research, and avoid use of new techniques until it has been tested and studied, as well as implement these strategies and plans to reduce global disability for low back pain. Main takeaway again is that the Lancet identified that we need to implement best practice, redesign our clinical pathways, sort of integrate health and occupational care, make some changes to our payment systems so people can afford care, or at least not overprescribe imaging so that it leads to surgeries and whatnot, as well as further disability and more healthcare costs. And then, continue to implement these strategies for improved public health and prevention. But they also went on to say that most of our systems and most of our healthcare networks are not really quite ready yet. So that's also the point of today, is to hopefully continue to build urgency towards new care or improved high value care. American College of Physicians are kind of a step ahead of it. In 2017, they updated their guidelines. And I found this to be very interesting, is that the way that they want to, or the way that they perceive low back pain, acute low back pain, and subacute low back pain is that it will resolve spontaneously, but they should avoid, all those pharmacological interventions initially and utilize more superficial things like heat, massage, acupuncture, spinal manipulation as initial treatment options, which I think is key. So that's considered high value care in my mind. In terms of chronic low back pain, the way that they suggest that it should be managed initially is through non-pharmacological treatment, utilizing exercise, multidisciplinary rehab, acupuncture, mindfulness-based stress reduction, amongst other interventions as well. I found this to be sort of the essence of what the biopsychosocial technique is the collaboration of prescribing pharmacology if it gets to that point, right? If the initial treatments aren't effective. They said that the physicians should collaborate with the patients based on the patient preference to prescribe either muscle relaxants or NSAIDs. And then as a last line, start to then prescribe things like tramadol, duloxetine, or other opioids if the initial treatments are not effective. So that's awesome. I think we're definitely starting to incorporate some of that biopsychosocial treatment. PTs are also along that same line. So the Lancet wanted to find what updated or best clinical practice is. In terms of PT, these are what we have that are most updated as of 2021 from George and his colleagues. They found that level A evidence for exercise for patients with chronic low back pain and chronic low back pain with leg pain is recommended, as well as level A evidence for thrust and non-thrust mobilization for chronic low back pain, as well as level B for patients with chronic low back pain with leg pain. What I found to be interesting is that they suggest education for all these patients too, and that they should use standard education strategies, but not as a standalone treatment. And their idea of what standard education is that they should use or give advice related to exercise and advice about staying active, basically walk or avoid sedentary lifestyles. Physical therapists should then also delve into giving pain neuroscience education alongside their other interventions like exercise and manual therapy, but neither of these should be standalone treatments, which I think is key. And that's what we need to implement as well for patients with chronic low back pain. The following year, Joe Godges and his colleagues released their low back pain decision tree on how we should address low back pain since it's been such an epidemic worldwide, right? One thing I found was kind of interesting was that all plan of cares, regardless of it being acute, chronic, subacute, et cetera, is that they all suggest patients to be able to be independent with self-management, and also that we need to prescribe pain education. And this is just stepping into my thoughts about this whole thing. This was an excerpt from the Lancet again, just to delve back into that, is that a lot of these conditions or the causes or triggers for nonspecific low back pain stem from poor mental health, psychological distress, and depression genetic influences. Such a key here, right? Amongst those other things as well, those important aspects of health, but such a key to consider some of the mental health aspects of their pain. This kind of expands upon it. This was a study from 1993 that I took from a course that I took with Joe Godges in USC back in October of 24. He mentioned this, that there were 200 subjects that were interviewed who came into a program, I think it was out in Texas, for a functional restoration program. And these were patients with real low back pain. They found that over 45% of patients who had low back pain also had depression, that 19% of them had substance abuse issues, 14% of them had anxiety. An important stat here is that 39% of those patients had depression prior to low back pain, but then 29% of them developed depression after their low back pain. So then it comes to this. Are we managing the individual cognitive aspects of our patient's pain? Are we looking at things like depression or their anxiety? Are we considering their personality traits, like if they have avoidant patterns or their paranoia towards their pains? Are they having pain catastrophizing behaviors or kinesiophobia where they're afraid of movement? Are we even thinking about their pain memories, how it sort of can elicit some of their peripheral sensitizations from just thoughts about what happened to their low backs? So my take is that the mind does matter. And I'm curious what the best way to educate, but this is my take on it. This is an interesting statistic that 92% of patients with chronic low back pain have kinesiophobia, and that we need to reduce or gear our treatments towards reducing this kinesiophobia. Adrian Lowe suggested that patient education has been long explored in the management of pain as well as anxiety, stress associated with low back pain. So it's obvious that education is key. From there was another study from Sullivan that looked at kinesiophobia specifically and the best way to address it. They found or defined that people with kinesiophobia or pain catastrophization, generally people who are more attentive towards their pain, and that it may stem from their cognitive errors or exaggerated perception of threat. How we need to treat that is basically with restructuring and changing their attention from catastrophic thinking. Sounds like we need to put our psychologist hats on, right? Or do we? This is the World Health Organization's take on how patients should be taking part in their own self-care education. Basically simple, right? Be more physically active, optimize their mental well-being, maintain a healthy body weight, not smoke tobacco, etc. Get good sleep, be engaged in social work and activities, make ergonomic adjustments. This is a handout that sort of encompasses all that. But is it enough? I think that the current generalized education that we provide our patients, like the World Health Organization, can feed into furthering fear, right? Furthering chronicity risk, leading to more chronicity and disablement. They say that patients should maintain their activities or stay active, right? That low back pain will spontaneously improve. But sometimes patients require a little bit more than that, obviously. That's why low back pain is individualized and generally won't improve with just generalized education or general rehab. We need to be more specific. Low back pain is challenging to diagnose too, which is why we're failing or why we have trouble with getting improved outcomes. And that's because 90% of it is nonspecific. We can't gear it towards a specific structure like a disc or a vertebrae. These are patients who have pain that come from the scrutinization process as well, at least those who are more chronic. And from there, imaging is overutilized and overfocused on, sort of reiterating what the Lancet had to say, as well as what Buckbinder had to say. And is it still being pushed too hard? I'm curious. It's hard to say that a specific structure is a root of their cause of pain, exactly. And so the biomedical approach needs to be less incorporated, right? Because telling a patient how to treat or what they should do and not really considering the patient's perspective can fuel more catastrophization, fear, and hopelessness. So how can we be better at influencing our patients' scrutinization of their pain, essentially? My take is that education without self-efficacy building can lead to an increase for chronicity. That general education and pain education alone is not enough based on the current practice guidelines and current best evidence. That we also need to address the cognitive aspects of their pain with self-efficacy building. There was a study from Wobe that suggested that a low sense of self-efficacy is associated with depression, anxiety, and helplessness. Some of these things that sort of fuel chronic back pain and chronic issues. Self-efficacy also, they found, is a greater predictor of disability than kinesiophobia alone. Just to take a step further into this as well, with the chronicity risk and self-efficacy, is that both appear to contribute to levels of pain and disability, but that self-efficacy also is a stronger predictor of disability than actual fear. And then to look into this a little bit further too, and why this can matter towards movement and improved overall health and lifestyles, there was a study by Hereho in 2017 that looked at the cortexes of patients who were coming off of strokes. A little bit unrelated in terms of low back pain, but nonetheless, people who are dealing with major health issues and chronic issues. People who have low self-efficacy have less prefrontal activation than the group in the people who had moderate self-efficacy, suggesting the evidence and the need for self-efficacy for people to be a little bit more active. Obviously, we know the prefrontal activation leads to improved execution of motor plans and ability to move better. So those patients who have higher self-efficacy, they're going to do better, obviously. And I think it's important that, like I said, we need to be clear on what is causing our patient's pain. That's where we need to start here, right? So how do we implement all this stuff that I'm talking about? We need to be clear in our diagnosis. Patients, physicians, PTs, we need that clarity. And the Lancet itself also goes forth to say that we need to discourage misinformation for physicians as well as patients. Adrian Lowe suggested that patients have a strong desire to know more about why they continue to hurt. My take is, in order for us to do this, we need to know why they hurt more clearly, or at least be more clear on what their pain type is. Hence, my proposal is that we need to be clear in identifying pain phenotypes. And this was taken from Dr. Correja and his expert PT model of thinking from 2023 that looked at symptom phenotypes as a major part within the overall outlook of a patient and their presentation, as well as how it can influence long-term results. We need to consider if patients have nociceptive dominant pains, like coming from a tissue, versus neurogenic related pains coming from a nerve, or is it more nociplastic, something that's coming from the cortex or that scrutinization process? And I think that's why we have, or at least part in why the chronic pain pandemic has persisted. We haven't been able to properly identify these patients well. And so we can be more clear from SMART. He released a likelihood sort of diagnostic framework when patients possess these three uh, highlighted traits here, that they have a strong association with maladaptive factors, pain disproportionate to the nature and extent of their injury mechanism, as well as diffuse non-atomic areas of pain or tenderness on palpation, that those patients have a 486 times likelihood ratio to have nociplastic pain or pain that's essentially stemming from the cortex. One way that we can sort of rule SMART's criteria in is we can utilize outcome measures. And it's sort of hard to rule in that someone has yellow flags or psychological or cognitive affective behavior issues until AOPT released their OSPRO Yellow Flag Questionnaire. So the OSPRO Yellow Flag Questionnaire informs treatment decision making and facilitates treatment monitoring for patients who are considered to be at high risk for poor outcomes. Basically, it allows for a quick assessment for psychosocial flags. It also incorporates at least 8 outcome measures, as you see here, like the FABQW and PA, TSK11, PHQ9, as well as the PSEQ, which is the Pain Self-Efficacy Questionnaire. There's 3 different styles of it from the OSPRO that use a 17, 10, or 7-item questionnaire with good probability and accuracy that those patients have yellow flags at 85, 81, and 75%, respectively. So that's how we can feel a little bit more confident that our patients have cognitive affective or cognitive behavior aspects or towards their pain. And then we can be a little bit more clear in using a decision-making tree to rule in nociplastic pain as well. This was taken from the International Association for the Study of Pain, which was released in 21. Going down from top to bottom, pain must persist for at least 3 months, right? That's a clear evidence that there's no tissue or that pain has persisted longer than normal healing guidelines. We need to be clear that the patient doesn't have nociceptive and neurogenic related pains, and we can utilize different testing like range of motion, manual muscle tests to rule in some more tissue-related dominance versus neural tensioning tests like slump signs and straight leg raises to rule in neurogenic related causes. But then from there, we need to rule in that the patient has hypersensitization, and we can utilize repeated pinprick testing to rule in something that's considered temporal summation. So that's when there's an excessive amount of overactivation of the periphery from the central cortex. So the way that we orchestrate that is we give a pinprick to the area of pain that the patient's having, get their visual analog scale of pain from 0 to 10, do 10 repeated pinpricks, and at the end, see if that pain level has increased. If it has increased, we can feel confident that patient has pain hypersensitivity phenomenon. And then from there, once they have all those different traits, if they have at least one comorbidity, we can feel probable that there is nociplastic pain and more confident that we have the correct diagnosis. But is it clear how to improve coping or treating the cognitive aspects, right? This was a chronic pain treatment flow chart from O'Sullivan and Schmitz, their 8th edition for physical rehabilitation. So this is kind of like a framework on how to treat chronic pain. But specifically, what I'm highlighting is the way that we can be more effective is in improving coping skills is stop catastrophization. That's one thing that we as clinicians should do for our patients, or at least foster our patients to stop catastrophizing. modify or challenge counterproductive negative thinking, and then teach patients skills to improve their self-perceived ability to manage pain. But is it really clear on how to do that? I don't know if, most physical therapists or most physicians know how to do that specifically. So that's what I'm proposing. This is a way that we can do that, right? I believe that if we can improve pain self-efficacy, that we can change patients' negative thinking and reduce catastrophization. So I believe with a three-faceted approach, using motivational interviewing and counseling skills, using pain science at various stages through the plan of care, and then teaching self-management or self-efficacy focused exercise or intervention strategies, that we can kind of give our patients the ability to put the Band-Aid on or just mostly self-treat, right? Not necessarily a Band-Aid because a Band-Aid's temporary, but really give them the ability to manage their issues. And that's the idea here. So where does all this start from? It starts from Bandura's original theory of self-efficacy, and it's that people's belief in their ability to control their functioning events that really affects their lives, and that when one has improved self-efficacy, that's the foundation for motivation, well-being, as well as personal accomplishment. I think that's the key here for how we can affect the cortex or the scrutinization process of the chronic pain aspects. From there, ways that we can improve or bolster self-efficacy is a four-step approach or four keys. You as a patient need to master an action. So if that for someone with low back pain needs to be able to bend forward and tie their shoe, they need to be able to do that appropriately with the help of a physical therapist. But from there, they also need to experience someone else do that with proper form and proper mechanics so that they can compare themselves to that. And then from there, once they've been able to master that performance of tying their shoes, just as an example, they need positive feedback from you as a physical therapist or a physician. And then from there, be able to reflect on how they did. And that's where the real change occurs from an emotional and physiological standpoint, is when they can self-reflect on their task execution. Sounds a lot like motor learning, right? Why this works, though, is that when we have self-belief, that's when we have improved behavior changes. And then it's really facilitated by one's having a little bit more control of their situation, right? Think about when you were a kid and you were told to brush your teeth. Were you going to do that just because your mom or dad told you? No, you're going to do it because you realize if you don't, you're going to build cavities, right? But it's a kind of a simple analogy here, but you realize that if you don't do that, it's going to lead to detrimental issues or results. Meaning that if you have more control of the situation, you're going to be better off and you're going to be less inclined to have more issues. So it's basically, as a person develops more self-efficacy, they have a better optimistic view of their capacity to deal with stress, life, etc. Specifically, what I'm trying to propose here is improved pain self-efficacy. And what it's defined as is a patient's belief or in one's ability to handle or accomplish a task despite discomfort, specifically low back pain in this case. The way it can be measured is through the pain self-efficacy questionnaire. It's out of 60 points. A higher level is considered better, obviously, and that a minimal detectable change is 5.5 points within that scale. Ways that we can address it, this was taken from a JOSPT study, is addressing it through cognitive behavior therapy, guided imagery, exercises, multiple component therapies, and that those people can then improve chronic musculoskeletal pain through building self-efficacy. This study from JOSPT, which I mentioned before, and I'll mention within the next slide, looked at ways to, what are some of the best interventions for building that, and they found yoga to be one. My thoughts are yoga is just the start of it, and we can utilize other concepts or frameworks or clinical reasoning skills and incorporate pain self-efficacy within. So one interesting study by Giuliani and Yannick was they found that pain self-efficacy was associated with improved treatment adherence, improvements in pain, disability, depression, and emotional distress. That's sort of how we're starting to get into that scrutinization or that cognitive behavior aspect or that kinesiophobia or that fear avoidance type of behavior, right? So that if we can start to address some of those issues, we're going to change the way that our patients interact with their pain. And again, this was a study that was taken from a meta-analysis of 8 studies with moderate confidence that patients with chronic diseases and higher self-efficacy tend to have fewer mental health problems and higher quality of life. So again, just to rephrase my proposal, the 3-tiered approach here is we need to utilize each throughout the plan of care, each with a focus on the patient leading and being in control. That's sort of that self-efficacy building, right? Having self-belief, having control of the situation leads to behavior changes, if you remember from a few slides back. And from there, this can reduce depression, anxiety, helplessness feelings associated with pain. So what is motivational interviewing? And this is kind of the key thing, right? If we can interview or talk to our patients in a way that bolsters their self-belief, we can be effective towards their pain. So what it is essentially is a collaborative goal-oriented method of communication that empowers people with depression to make behavioral changes. It's really a focus to facilitate patients' reflection on their ambivalence of their logic or theory towards their pain specifically is what we're looking at. And then from there, use their own motivation, energy, and commitment to change behavior. Joe Godges, which again, I mentioned before that I took a course with him out in USC in 2024 of this past October, you phrased it as the art of skillful guiding. An example of that is, what do you think makes your pain better? It's a simple phrase, but it allows the patient to sort of delve within their cognitive aspects and really evaluate and reflect on what's going on with their symptoms. And that's where they can get a little bit more control. From there, what is it really? It's a motivational mindset. And it's important that we as clinicians or physicians start to incorporate that with the way that we speak to our patients to really start to bolster that self-efficacy. It's essentially a collaborative approach where patients are included and it's a joint decision making versus us telling them this is what they need to do. You need to do 3 sets of 15 of bending backwards in order to help your pain versus they need to sort of make that decision with your help. And it needs to be evocative, right? You need to utilize things or motivations that are really going to affect them. Like if you can't bend forward to pick up your child, how are you going to get them from the crib? Things like that. Make it relatable to them so that they then begin to honor their own autonomy and they have more control of things. Motivational interviewing aims to really just increase the quality of life and self-efficacy behaviors of individuals with chronic diseases. So that's why I think it's an essential part of this 3-tiered approach like I'm suggesting. A key piece of having a motivational interviewing skill, though, is counseling. Now, I'm not saying I'm a psychological specialist. I don't have a whole lot of training within that other than what I took out at USC with Joe Godges, but it's simply a way of interviewing, right? It's using listening skills and action skills to help promote a patient's self-responsibility and self-efficacy. By listening and listening intently, like really attending to them, it gives them comfort, but it lets their defenses go down, right? It makes them feel more heard and validated. Saying things like, I see, and I hear you, right? When you do that, it really just gives the patient that you have their full attention and that they can really feel safe around you, which is super important when we're thinking about the biopsychosocial approach. And then from there, when they have this belief that you're there to really help them, then from there, they're going to be able to open up. And then from there, they can start to lead you and you can guide them towards the recovery. So asking open questions is important too. Avoiding closed-ended questions like, does that hurt when you do that? Versus, could you explain how that feels when you do that? Or tell me a little bit more about what you think. Those, again, allow the patient to sort of peer within their thought process and be able to sort of figure out if their reasoning is correct or not. And then another skill of motivational interviewing is confronting, right? Confronting is sort of where we can really make changes and where our patients can change their beliefs on their ways of thinking. But it's got to be done sort of cautiously and non-judgmentally. And from there, if we do that effectively, the patients can explore their discrepancy and really gain a more clear picture where they need to change. That's where we can be more effective with our patients who have fear avoidance, kinesiophobia, that have sort of these paranoias towards their pain, is when they start to realize how they sound or how they are thinking about what they're thinking about. That's when they can really make big changes here. So an example of this, I had a case a couple weeks ago who had a recent ICD implant within her left arm. And she was so concerned that she couldn't comb her hair that she was going to dislodge the wires. And it was one of these situations where I stated it simply and utilized some of these motivational interviewing skills. And I just said, tell me if I misheard you, but you mentioned that moving your shoulder to comb your hair will dislodge your ICD, right? And from there, it gave her the opportunity to sort of reflect on how that sounded. And then she said, well, my physician said I should avoid high impact things like golf and swinging a golf club and playing tennis. I said, well, tell me if it makes sense to you that golf and tennis is the same as combing your hair. And that was my ability to confront, right? That was my ability to sort of call out her logic, but then give her the opportunity to reflect on that. And then from there, I sort of continued on, right? And I let her lead me through. So I said from there, can you tell me anything else you're afraid of, right? Is there something else that you believe will dislodge your IED wires, your ICD wires? So then from there, we went through, she was afraid to do a push-up. She was afraid to do specific exercises like military presses or things that she needed to really do in order to function with her everyday life. So I listened to what she had to say. I restated or clarified some of the concerns or fears that she had. And then ultimately, between the two of us, we went through an actual yoga session where we went through down dog and child's pose, where her head and her shoulder were completely weight bearing overhead that initially addressed her main fear of not being able to comb her hair. When she left, she was feeling much better and more confident, and that she had more control of her situation, that she wasn't going to dislodge these ICD wires with any simple move, which was pretty cool. Pain neuroscience education is the second facet, and I think the way that we do this and deliver it can be somewhat misconstrued. If I'm trying to bolster self-efficacy, I don't want to talk about all the biological and physiological approaches to what pain is, looking at alpha motor neurons and delta neurons, et cetera. All that's going to do is continue to breed more fear and anxiety about their situation, depending on the patient, right? Obviously, there's certain patients that need to hear these situations or hear these phrases a little bit more clearly. But generally, I'm going to keep things a little bit more in terms of how their movements or how their fears, what sorts of pains come from that. And if it's a positive pain, a negative pain, or something that they should be okay with. Is it a stretch pain? Is it a burning pain? That suggests maybe more of a nerve. These sort of things that patients need some clarity on. That's sort of my take on pain neuroscience education, rather than getting into the technical jargon of what nerves are and what pain is. Like I said, that can sort of bolster or raise levels of anxiety and fear associated with it. But nonetheless, there are simple strategies and ways that we can incorporate this that are a little bit more standardized from Adrian Lowe. We can utilize stories or flashcards, use relatable analogies that make sense to the patient. And these are usually best delivered verbally one-on-one in roughly 30-minute sessions. With my patient I was talking about before with the ICD, I mentioned that, the reason why her shoulder is hurting obviously is her nervous system is a little bit more sensitive. The analogy that I used was, her door, or, that her nervous system sort of like a door at Walmart. When you go close to it or when you try to move that arm, the alarm system or your door from Walmart is hypersensitive. When you walk up to that door, it's going off or opening from 20 feet away. Whereas, someone who has less of a heightened alarm system, their door's going off within 2 feet or whatever within normal limits it would be. And that by doing some of the things that we talked about before, like yoga and weight bearing, overhead movements, that's a way that we can desensitize or sort of make her door open up more normally. And it's really that simple. Just give some relatable things that sort of give the patient a little bit more clarity on what they need to do. That's my take on pain neuroscience education. Why does this really matter, though? Why should we incorporate pain neuroscience education? I mean, there's been many studies out. One recently from 2024 looked actually at how after delivering pain neuroscience education, that there's a reduction in pain sensation within the cortex, and that because there's a depression within the pain or the neuromatrix or like that pain signature within the cortex, that there's an increase in motor activation. And from there, patients who, after getting P&E, can perform movements a little bit better and more efficiently. So like they said, they found an improved prefrontal cortex activation, which is pretty cool after utilizing P&E. So that's why I think it's important to incorporate within our plan of cares, but to do so sort of with that motivational interviewing or self-efficacy building type of background versus just speaking jargon or speaking medical terminology to build into that biomedical approach that has led to more chronicity and disability worldwide. So again, this all sounds fairly good, right? Again, though, the Lancet suggests that we need to be clear on what the best evidence is towards treatment of low back pain, and that it suggests that P&E is not enough alone. And again, this is just reverberating a little bit more of what I'm saying, that talking about pain can lead to biomedical focus, anxiety, kinesiophobia, and that sort of our patients being able to self-treat or give their own proverbial Band-Aid is through guided self-efficacy based exercise with P&E that is sort of collaborative using that motivational interviewing type of approach. So again, some principles here that I believe have an inherent ability to build pain self-efficacy are getting patients sort of to end range movements that you would see with, with the clinical reasoning of a McKenzie approach, utilizing mobilization with movement that you would see with, an approach or a background or reasoning from Mulligan. And from there, provide stabilization-based exercises, all of these with incorporating facets 1 and 2, utilizing motivational interviewing throughout the plan of care and PNE, but giving sort of that red light, yellow light, green light feedback and having our patients understand that red light's obviously bad or green light's something they should be doing, that helps them have more control. And that's the idea on building self-efficacy, right? Self-belief, self-control leads to behavior changes, which is essentially how our patients can improve their ability to function regarding their low back pain. So specifically speaking, self-management with utilization of exercises from the McKenzie method, using end range extension or end range movements, and giving that red light, yellow light, green light type of feedback can help our patients really build self-management techniques and strategies, as well as help them self-control their symptoms, right? As they're performing movements that they're afraid of, giving them the red light versus the green light allows them to sort of understand a little bit more about what they can do. And it's super inherent within that McKenzie framework of thinking, which I think is super important that we could start to incorporate in a way that we can actively incorporate within our practice. The caveat there is that we start to utilize that counseling or motivational interviewing type of speech with it to really bolster self-efficacy, using guided interview questions like, tell me if you think that movement helps your pain. Would it be reasonable to avoid the movement that makes you worse? Again, this is all sort of ways that our patients can feel a little bit more confident towards their self management. Stemming from sort of like a Mulligan type of background, a mobilization with movement, right? As you see in the bottom right-hand corner, a patient with a mobilization belt. When you give them this exercise with the red light, yellow light, green light type of feedback, and then explain to them or use motivational interviewing type approaches, tell me if you think that stretching with a towel helps you move better, if it feels safer to move better. Those sorts of phrases and the way that you frame it towards your patient is really what I'm proposing here. That if you incorporate that type of language with utilizing some of these patient self-driven or self-mobilization techniques, that they can really bolster improvements in quality of life, kinesiophobia reductions, as well as reductions in depression. So it's super, I think, imperative that we can incorporate all three of those facets, like I mentioned before, but utilizing some of these techniques where these patients can just have more self-control and self-management. And again, stabilization is another example, right? This is so simple and practical for our patients because they can perform it anywhere. They don't need a belt or they don't need, anything like a specific piece of equipment in order to perform it. They can do it at home, right? But the deal is that if you give them that red light, green light type of background and feedback when they're performing some of these movements, like if you have them perform a core stabilization exercise where they do an abdominal draw-in maneuver, start to march their knees, and from there, if they're starting to feel sharper pain, give them that feedback that that's something they want to try to avoid, or how they can, from there, draw their abdominals in a little bit more. Give them the green light or the red light with that, right? And if you use that guided interview, tell me if you think building your control of your low back pain muscles will help your pain. I'm simplifying these statements here, but I think getting the idea on how we need to talk to our patients and how we can incorporate self-efficacy building with some of these foundational approaches towards treatment is key. And I think where we can really make a big change in some of the cortex or scrutinization issues associated with cognitive or chronic back pain in general. So here's the idea. Again, just restating that when patients have better self-belief, that's when they're going to have improved activity change. That when we give exercise prescriptions and self-management strategies with the intention of building self-efficacy as a key, that this can complete a shift in our patients' behavior towards their pain, can lead to reductions in depression, hopelessness, fear, kinesiophobia, and overall limit chronic risk development or disability. And this sort of brings it all together here. Based on the Lancet, the National Institute of Clinical Excellence from London, current clinical practice guidelines from the ACP, AOPT, is that we need to treat low back pain immediately with conservative measures versus pharma and imaging, and that the patients need to collaborate with the physicians in doing so. We need to address low back pain and figure out the actual pain phenotype first so that we can be more effective with our treatments. From there, address nociplastic phenotypes related to chronic back pain and the patient's catastrophization or negative beliefs by utilizing pain neuroscience education, but also bolstering pain self-efficacy education. And from there, use self-management building skills through motivational interviewing and counseling, movement or exercise or mobilization techniques to desensitize the central nervous system and peripheral nervous system and sort of bolster or foster overall wellness. But the key here is that it's collaborative and that our patients are going to help lead while we guide, which is the key towards building self-efficacy and overall reducing some of those other cognitive aspects like depression, anxiety, that can really lead to the scrutinization issues and development of central and peripheral sensitization. And just so you know, it's starting to catch track here with all these, worldwide, we're starting to see self-efficacy built within different approaches for different backgrounds like ACLs, different diagnoses like impingement syndrome, even looking at how it affects coronary heart disease. So I think it's really something we should start to take note and start to utilize and apply within our treatments. And keep in mind, while we're doing this, the idea is to empower our patients. And that's my hope here, is that what you take from this presentation, that the way that we talk to our patients, the way we educate them truly matters on the way that they scrutinize their pain, and that if we can empower them with self-management training and self-efficacy building, that we can really be effective at reducing disability worldwide. So with that, guys, thank you so much, and open to any questions.
Feel to type into the chat your questions or unmute yourself and ask.
Go ahead, Katie. Oh, that's a great question. So is the PSEQ available for us on photo or should it be given separately? I believe it's not. I can actually would be an interesting thing to try to incorporate within photo if we need that. I think we can access it online and print it out and give it if we need to. Right now, I think we utilize the StartBack tool as a way to sort of evaluate risk for chronicity development, which is actually something me and Steve are doing some research towards, which is interesting. But no, I think that would be an interesting way to, or something valued that we could incorporate potentially. So, anybody else?
Trying to change the paradigm, especially if they're very biological model. How do you start to address them?
Yeah, great question. So how do we address patients that are a little bit more resilient to being challenged mentally or towards their level of thinking, especially regarding their pain? It's one of those things where how can you get the patient to reflect more, right? And I think if we can sort of, proverbially dip the toes in and have, just create situations or, use specific examples of what they're actually fearful towards. And from there, just give feedback in terms of, is this something that seems logical to you, or is this something that seems, is this a healthy way to interact with your thoughts or the way that you're interacting with your pain? Is something that, is tactful, but after you've developed enough of a therapeutic alliance with your patients, I think, depending on how that alliance is, you can delve into that. But it's obviously something you don't want to do from day one, right? It's something that you're going to have to take a couple days or a couple treatment sessions to sort of incorporate within. Those patients, may take several visits to get to that point. And it's just one of those things you just have to sort of play and feel as you go. So,
Thank you.
well.
Well, if you think of anything, please feel free to reach out to Dr. Furst and myself, and we'd be happy to answer those questions. Again, make sure that you complete your quiz and your course evaluation after watching this, and we will see you next month. Thank you very much.